Hello dear students, so the topic of discussion for this video is going to be Nekams disease, which is also called as Keratosis Lichenoides Chronica, Porokeratosis striata lichenoides, Lichen verrucosus et reticularis, Lichen rubor acuminatus verrucosus et reticularis, lichenoid trikeratosis. So there are so many names, but you can remember in the examination Nekams disease and Keratosis Lichenoides Chronica would be asked. So, what is the pathogenesis of this condition? Remember, this is a rare disorder considered by many to be an unusual variant of lichen planus or an atypical isomorphic or Kibner's response. Primarily affects adults aged 20 to 40 years, but occasionally it is also seen in the children. It is a chronic, progressive, and highly resistant to therapy, and cases have been reported following trauma and erythroderma. So remember, this is a rare disorder, but once it comes, it's going to stay for long. So this is a chronic and progressive, and it is very highly resistant to therapy. And clinically, it is going to present as violaceous or erythematous verrucous keratotic papules and nodules, which are arranged in a distinctive linear and reticulated fashion. So that is the reason why the other names were consisting of these terms reticularis, keratosis, and so on and so forth. Coming to the distribution, they are symmetrically distributed, favoring extremities, the antecubital and popliteal fossa, extensor, forearms, posterior thighs, buttocks, lumbosacral areas. And here in this picture, you can clearly see the linear fashion of the lesions, and also some of the lesions are showing this reticulated or lace-like network-like pattern, which you also can see in the lichen planus Wickham's tray, if you remember. Okay, so this is yet another picture where you are able to see this Nekams disease, which is presenting as a verrucous lesion over the knees. So coming to the morphology, the lesions are usually covered by hyperkeratotic plug. Removal of the plug is difficult and reveals irregular indentations and prominent capillary loops. If face is affected in this condition, it will present as a rosacea-like or seborrheic dermatitis-like changes. That is, in the rosacea, they are going to be erythematous telangiectatic areas. But if it is seborrheic dermatitis-like, we can see yellow, greasy, crusted plaques, which are oftentimes appearing like psoriasis-like scale. So we call it a psoriasiform scaly plaques. Even mucosa can be affected. It is observed in almost 50% of the patients of KLC. Features will be recurrent aphthous ulcers, larger chronic ulcers, or erythrokeratotic papules in the oral cavity. Genitalia could also be affected, but it is very less common compared to the oral mucosa. Palms and soles can also be affected when we describe the lesions as acral, obviously, and we can see keratotic papules on the palms and soles. Nails can also be affected. They can become thick and they can show longitudinal ridging, and usually they are prone for paronychia. Scalp may also be affected. If in doubt, if we do a histopath, the picture is going to be almost similar to lichen planus. That is, lichenoid tissue reaction would be there. So we can see the band-like lymphocytic infiltrate at the derma junction. But in this case, we can also see the parakeratosis with neutrophils in the crust. And oftentimes it may also come to be non-specific, and it may be consistent with the chronic dermatitis. But lichenoid features are commonly observed on many histopathological pictures of the KLC patients. Even immunofluorescence is identical to the idiopathic lichen planus. Coming to the treatment part, the mainstay and the most successful treatment till date is PUA therapy plus or minus the oral retinoid, which is the acid retin. Other options are available definitely, but they are mostly unsatisfactory when compared to the mainstay or most successful treatment. They could be topical systemic corticosteroids, other steroid sparing agents like methotrexate, cyclosporin, and UVB therapy. So this is about the Nekams. I hope it was helpful. If so, please do that like button and also do let me know in the comment section if more such short and sweet videos are helpful for you. If so, I will make more such videos on a regular basis. Thank you so much. Happy learning. Bye bye.